So next up, we have Dr. Ben Rapoport. Ben and I have known each other a long time. We were residents together. He completed his undergraduate degree at Harvard, followed by a master's at Oxford and a PhD at MIT, and then his MD at Harvard Medical School. He then came back to New York, where he is from, to complete his residency training at Cornell, followed by including enfolded fellowships in endovascular surgery and endoscopic skull-base surgery. Dr. Rapoport focuses his clinical attention on brain tumors, skull-base pathology, and minimally invasive neurosurgery, and he is the scientific director of Mount Sinai BioDesign, leading a team of postdocs and PhDs who are developing ideas from clinicians, among other things, into commercially viable products, among other interesting academic endeavors that he can tell you more about. He has authored a number of peer-reviewed scientific publications and has 10 patents, possibly more, by the publication of this slide. And he's going to give us an interesting talk today.
Thanks, Peter. And thanks so much for having me, my slides up on the screen here. Are you seeing my slides properly?
Yes.
Great. Is my audio okay?
Yep, perfect.
Yes, and
Great.
Thank you for asking.
Okay, all right. Great. Well, thank you so much for having me this morning. I'm going to speak about a project that we've been working on collaboratively in the department for about a year now, on tumor embolization in particular and meningioma embolization specifically. This is really collaborative work in progress, and I'd like to spend some time this morning sharing some initial results and really asking for feedback and insight from the group. And maybe for those who aren't familiar with the work, I hope to begin to change your mind a little bit potentially about tumor embolization. No financial disclosures, but as Peter mentioned, some of the work that I'll be discussing this morning is taking place within BioDesign. So I do hope that there will be translational and commercial potential related to some of what we'll discuss this morning. I just want to begin by thanking a huge number of people who've been involved in the work that we'll be discussing, because this has really been a very collaborative effort. The study involves both the cerebrovascular group. Basically, everyone in the left-hand column has treated and enrolled patients in this work. Everyone in the middle column has operated on patients that will be discussed today, and everyone in the right-hand column, that includes both research fellows and residents and PhD students in BioDesign, have contributed to data analysis and ongoing work. So it's a great, very interesting collaboration, very fruitful, and I want to thank everyone who's been involved over the last year. I'm going to begin with a personal anecdote, just to share really how I got interested in this subject of meningioma embolization. And I think this anecdote in some ways encapsulates a number of the key issues as I see them in tumor embolization. So these images are images that I saved in my iPhone for past 5 years. This is a case that I was involved in as a resident. It was an elderly woman who had a large convexity extending to the sphenoid wing meningioma, and she was referred for preoperative embolization. And where I trained at Cornell, the practice was, as it is in many places where preoperative embolization is done, to embolize the tumor the day before surgery. And the workflow, which I think is the most common workflow, at least in the United States, is for the patient to arrive at the hospital on the day of embolization, to be admitted for embolization, and then admitted post-embolization, and go straight to surgery, usually the next day. And as a result, the patient has usually their preoperative MRI is done on an outpatient basis, and they don't have another MRI until the postoperative period. So there's never usually a chance to see what happens on some level after embolization. This patient, just for logistical reasons, the surgery wasn't, the embolization was done on a Thursday, and the surgery was done on a Monday. And so the patient was in the hospital over the weekend, and her preoperative planning MRI was done the Monday morning, the day before the day of surgery. And so what I'm showing here on the left is the outpatient preoperative MRI on the left here, showing an avidly contrast enhancing tumor. And the right-hand panel is still a preoperative MRI, preoperative contrast enhanced MRI. But it was done after the tumor embolization, 2 days after the tumor embolization. And obviously what you see is that the tumor, which was extensively embolized, I don't have the angiographic images, but don't worry, there are plenty of those coming later in the talk. Extensive embolization and almost complete loss of contrast enhancement in the tumor. And at surgery, this tumor was completely liquefactive necrosis, basically, totally aspiratable, very straightforward resection, which was fortunate for an elderly patient who could have had obviously a complicated operative course. So this episode kind of sparked my interest in the whole subject of what happens with tumor embolization, because I think many people think, and certainly the literature reflects, that embolization preoperatively is all about blood loss. It's all about preventing operative blood loss. But this case really set me to asking the question of, is there something else besides limiting blood loss that tumor embolization does to the tumor in the preoperative period? And are there other ways we should be thinking about why to perform embolization and how to assess the efficacy of embolization? So with that as a kind of prelude, I'll jump right into what we've been doing. So I'm going to talk first a little bit about technically how meningioma embolization works, and I'll show just a little bit of the evidence on whether or not it works, and there's certainly disagreement on that subject. And then I'll talk about the work that we've been doing over the last year, starting with what seems to happen angiographically, radiographically, otherwise, when a meningioma is embolized. And then we'll talk about how do we assess the efficacy of tumor embolization, and that's not a straightforward question. And then I'll talk a little bit about our experience here over the last year, and maybe even a little bit before that. And we'll talk about ways that we've been approaching quantitation of understanding the efficacy of tumor embolization and meningioma embolization in particular. And this is work done by one of the PhD students who's working with us in BioDesign, an engineer from Rensselaer Polytech, Denzel Faulkner. And then we'll talk a little bit about future work and where we hope this is going. And I hope that we'll get also to questions about whether it makes sense to think of alternative ways of approaching these tumors once they are embolized. So how does meningioma embolization work? Many people are familiar with the process. So just as an overview, a patient undergoes a catheter angiogram, and that's what is shown here. Here you have a patient with a large sphenoid wing meningioma in the left-hand panel. And in the preoperative period, usually a day or more before surgery, the patient undergoes a diagnostic angiogram. And here what you see in the middle panel is an external carotid injection, which in the AP and lateral projections shows you the vascular blush of this sphenoid wing meningioma. And after fully characterizing the vasculature of the brain and the tumor, the feeding arteries are selectively microcatheterized, and through a microcatheter, any of a variety of embolization agents can be used to embolize the tumor, and those include glue and onyx particles, and there are other options as well. And we won't get too much into the specifics of the embolications. I think I'll reserve that for another talk. There's a ton of interesting engineering going into that right now, but we'll reserve that. And so here what you can see is that the tumor, which has a very avid vascular blush, has been, at least from an angiographic standpoint, completely devascularized in the right-hand panel here on the post-embolization angiogram. And we say that shows a loss of tumor blush. So, well, this has been done for decades. And what do we know about whether it works? And what we know about whether tumor embolization works really depends on how we define works. And to date, over the last really 2 decades, the goal of preoperative meningioma embolization has been to reduce intraoperative blood loss. And I'll just say this is a very controversial topic, and there are a number of meta-analyses out there, 4 of which I've just put on the screen here, and they are conflicting. Some of them suggest that that there is no difference in intraoperative blood loss from embolized meningiomas, and some suggest that there is a benefit in terms of blood loss, a reduction in blood loss, a reduction in operative time when meningiomas are embolized. Of course, there's tremendous bias in which tumors are sent for preoperative embolization in the first place. And I would also point out, and the residents probably heard me say this a number of times, that the whole idea of trying to quantify operative blood loss is pretty difficult. And as we all know, estimated blood loss in a neurosurgical case, at least, and probably in most cases, is not really a particularly good measure of actual blood loss. Sometimes it's almost a random number. So when these cases are retrospectively reviewed and blood loss is taken as an indicator of efficacy, one has to view that with a certain degree of suspicion. So one wonders, is there something else that we can measure? And is blood loss even the whole point at all? And of course, total blood loss in a case is not just tumor-related blood loss. There's also blood loss from the exposure. So there's all kinds of issues to wonder about in how the efficacy of meningioma embolization has been interpreted in the literature to date. So I think that we'll have something to say about that through the Mount Sinai experience over the last year and beyond. Well, what happens to a tumor after embolization? Let's talk about what happens angiographically. We sort of showed that in the last slide. From an angiographic standpoint, the proceduralist tries to devascularize the observed tumor blush, and this is exactly what I was showing in the previous slides. But what happens on MRI? And as I mentioned, in most institutions, it's not common to obtain an MRI after embolization of the tumor. That would be a 3rd MRI scan. Usually patients obtain preoperative, which would be a preoperative pre-embolization MRI, and a postoperative MRI, which would be a postoperative and post-embolization MRI. But of course, that leaves no way for MRI imaging to assess the effect of embolization alone. And what we've been doing over the last year here is to obtain a 3rd MRI. We have a study protocol that we've put in place last year that involves obtaining an MRI after embolization and before surgery. And that has given us a real window into understanding some things about what happens to these tumors after they're embolized. And this is an example of that. And so in the top left, you see the axial post-contrast preoperative pre-embolization MRI. And in the bottom, you see the corresponding diffusion-weighted sequence. And in the top right and the bottom right, you see respectively the post-embolization preoperative contrast-enhanced MRI. And what you can see is that after embolization, there is almost complete loss of contrast in the tumor. if you don't look carefully, you can almost think that that there's been a tumor resection, but there hasn't. And in the bottom here, you see some diffusion changes as well, reflecting maybe early tumor necrosis. And not in all cases, but in many cases, there is a major change in the texture and firmness of these tumors, which really facilitates tumor resection. And I'll show you some examples of that. Here's another case. This is a parasagittal meningioma that we embolized preoperatively. So here are the preoperative pre-embolization axial, sagittal, coronal sequences. And here are the corresponding, some of the corresponding images from the angiogram. These are just microcatheter injections. So on the left-hand panels, you see the some AP projections of microcatheter selected some microcatheter injections. This one on top is showing you an injection through the middle meningeal artery, and you can see in the late arterial early capillary phase, you can see the tumor capillary bed being filled with contrast. And you can see a similar sort of picture in the lateral projection here on top. And in the right-hand panes, you see this is actually taken during injection of onyx into the tumor, and you can see the liquid embolic agent really penetrating into and filling the tumor. And finally, here in the bottom left, you can see that we've injected liquid embolic agent from both middle meningeal arteries. One of them crosses the midline to fill part of the tumor, and you can see this cast of the embolic agent filling the tumor and some parts of the middle meningeal artery. And we've, as I'll say a little bit later on, some of this vascular anatomy is becoming increasingly familiar to the group, because there's just so much experience now here and across the country embolizing middle meningeal artery pathology in the context of subdural hematoma. And I think actually there's some very interesting overlap in these pathologies, which I'll discuss a little bit later on. So here again on top is the preoperative MRI, preoperative pre-embolization MRI. And on the bottom, we have the still preoperative, but post-embolization MRI, corresponding sequences, axial, sagittal, and coronal. And again, what you see here is extensive loss of contrast enhancement in the tumor. And now, what does that actually mean from the surgeon's standpoint? So I want to give you a sense of that. So these are some images taken from the case. So I'll show you a video in a second. But here the tumor, here you're seeing the tumor capsule has just been incised, and the tumor is basically completely, almost 100% devascularized. And it has this sort of marshmallow fluff appearance to it, which makes it completely aspiratable and very easily handled at surgery. And let me see if I can play this video, just giving a sense of how this tumor handles after embolization. So again, the capsule has been incised, the tumor is basically being split in half, and you can see there's almost basically complete devascularization of the tumor. That silver there is the onyx cast of the embolic agent, and the tumor in this case is basically completely aspiratable from the inside. And here's a piece of the tumor on gross pathology. So that is all by way of sort of motivation. And now I want to ask the question of, well, again, what determines the efficacy of embolization? Both how do we measure how effective the embolization is, and what are we trying to achieve in the first place? Because 20 years of looking at this problem have really defined embolization efficacy as in terms of intraoperative blood loss. But I'd like to ask the question of, can we define a concept of embolization efficacy beyond simply intraoperative blood loss, knowing that, or at least thinking that embolization has some impact on these tumors beyond just devascularization, to somehow improve the ability to handle the tumors intraoperatively, as I was just trying to show in some of these cases. And another interesting question, and really an important one to ask, is what is an important control? And this comes up all the time. People say, well, how do you know that the tumor wasn't already a marshmallow fluff before you embolized it? How do you know that the embolization is responsible for changing the consistency of the tumor? You only have one shot to operate on it, so you can only open the head once in these cases. So how do you know that what you did had any impact? And that's a challenging question to answer, but I do think that these additional MRI sequences, post-embolization, pre-surgical, are going to shed some light on that subject. And there are a number of additional variables that come into play, and those include tumor location, vascular anatomy of the tumor biology, because we're actually, of course, embolizing tumors that are not just meningiomas, but today we're focusing specifically on the meningiomas, and even within meningiomas, there's a fair amount of heterogeneity, as you know. And then, of course, there's differences in the embolic material, so we can use particles, glue, onyx, or coils, in some cases other things. And then, of course, there are differences from surgeon to surgeon in embolization technique. And there are differences in the timing of embolization relative to surgery. So as I mentioned before, in many institutions, the most common practice is to embolize the day before, or sometimes even the day of surgery. Whereas in Europe, for example, it's more common to wait several days between embolization and surgery. And there's a thinking around that perhaps if there is some early tumor necrosis that is happening after embolization, does it even make sense, perhaps intentionally, to leave a couple of days between embolization and surgery? So all of these variables are potentially important. And how do we go about weighing their relative contributions in a systematic manner? So I'm going to focus really the current discussion primarily on the anatomic variables, and we'll save some of the other variables for future conversations. And in the next few slides, I want to give some intuition around the thinking on anatomic variables that have the most impact potentially on what we'll come to define as the efficacy of meningioma embolization. So here's another case, a convexity meningioma, not too different from the parasagittal one that I showed a few slides ago. Here's the preoperative pre-embolization MR study. And here are some views from this patient's embolization angiogram. And what I want to highlight here is both the different contributions, the different vascular beds contributing to this tumor. So on the top left, you can see that the tumor is substantially fed from branches of the external carotid artery, in particular her middle meningeal artery. And we did in fact, both middle meningeal arteries, both the left and the right, contributed to this tumor. But also, you can see this in particular after the embolization has been performed. There is a contribution to the tumor, especially to the sort of peel surface of the tumor, from internal carotid artery branches. And I didn't say this explicitly, but we really seek not to embolize through internal carotid artery branches most of the time, certainly not MCA or ACA distal branches. And what I want to highlight here is that in many cases, what limits the extent or the efficacy of embolization of these tumors is the degree to which they are vascularized by the internal or external carotid branches. So here, what you're seeing in this image with the arrow is after the tumor has been embolized through the bilateral meningeal arteries, there is a residual filling of the kind of inferior aspect of the tumor from distal branches, in particular of the middle cerebral artery, also from the anterior cerebral artery distal branches. And you'll see that this tumor was, at least on our post-embolization MR assessment, was not completely embolized, although, of course, we don't know totally what this means, but now we're looking at the contrast enhancement pattern following embolization. And you can see that there has been loss of contrast enhancement in the more superficial aspect of the tumor, but the deeper aspect of the tumor, the inferior aspect of the tumor, retains its contrast enhancement. And that corresponds to this part of the tumor that you can clearly see still has its vascular blush after the external carotid feeders were taken. So I'm trying to kind of compile a compelling body of circumstantial evidence to try to convince those of you who are skeptical that there's a clear relationship between what we see angiographically and what we see on MR. And this is not typically how tumor embolization has been evaluated. So I'm trying deliberately to make as compelling a case as I can. Here's another case. This is an orbital roof meningioma, and I'm not going to show quite as many images, but again, similar idea here, okay? So on the left, axial sagittal coronal views, pre-operative, pre-embolization of this relatively large and avidly contrast enhancing meningioma. And in this panel here, the second from the left, you can see the post-embolization preoperative MRI. And again, you can see that a chunk has been taken out of the contrast enhancement pattern after embolization, but there is still a lot of contrast enhancement. And why is that? Why were we not able to embolize? Why were we not able to reduce the total contrast enhancement to near zero? And the answer is that this patient had, this tumor was fed both by the middle meningeal artery and, as is often the case in medial sphenoid wing meningiomas and these orbital roof meningiomas, by branches of the ophthalmic artery. And because of the high risk, or at least the greater risk, trying to embolize through the ophthalmic than through external carotid branches, we did not, and typically do not, embolize through the ophthalmic. And so whatever portions of the tumor are still being fed by the ophthalmic artery are still basically appearing to contrast, to enhance with contrast in the post-embolization MR. And there's a certain amount of let's call it hand waviness to the explanations here. I'm trying to tell a story, and not all of the. I'm trying to convince you without all of the rigorous data yet required to do so. But I want to at least give you some intuition into where the hypotheses for some of the studies are coming from. So all of that, in a sense, is really just intuition and motivation. And now we want to try to see what we can do to make some of it rigorous. I hope I've at least convinced some of the skeptics that there's more to meningioma embolization than just limiting blood loss alone, and that there may be some utility to looking at the contrast enhancement pattern on the post-embolization preoperative MRI as a way of understanding what's happening to the tumor on some level. And so we have put together a study protocol that allows us both to do both retrospective and prospective analysis of the radiographic imaging, both angiographic and MR, and also to allow us in a prospective manner to obtain additional MR sequence in the post-embolization preoperative period for these patients. We have in the 2016 to 2022 period here at Mount Sinai embolized almost 100 meningiomas, and all of those were in the process of evaluating in a quantitative fashion. Where there's additional MRs, we have been doing it in a quantitative fashion, and where there is just angiography in a kind of semi-quantitative fashion. And to date, in the last year, we have almost 30 patients in this 3 MRI series. And all of those, as I'll show you in the next few slides, have undergone volumetric quantitative analysis. And so what we've tried to develop, and hopefully I hope I've justified it in at least an intuitive fashion. We've tried to develop this notion of extent of embolization, and the terminology there is meant to kind of reflect the terminology used for extent of resection in tumor surgery. We don't know if it's efficacy of embolization. We can say it's extent of embolization as defined by the degree of contrast enhancement on the post-embolization MRI, just the exact same way that extent of resection is defined when you're talking about tumor surgery. And so what we've been doing is for every case that comes and has that additional interim MR study, we have been going back and doing a full volumetric analysis of the case. And here's how we do it. So we basically take the in the initial presenting MRI, we compute the volume of the tumor before any intervention, and then in the post-embolization period, we measure the contrast enhancing volume of the tumor and the non-contrast enhancing volume of the tumor before resection, and we define that. We've been defining the extent of embolization in just the same way you would define the extent of resection if this had been a resected tumor. And so the percent, we give it as a percent of embolization is basically the percent of tumor volume that is non-contrast enhancing on the post-embolization MRI. And so I'll show you just a couple of cases, but I think you can understand what's going on here. So here in the left-hand column is the pre-intervention case. Here in the middle column is the post-intervention, the embolized tumor that has been segmented. And this does require computer-aided analysis because the shape of the contrast enhancement pattern is often kind of tricky to handle. It's not something that you can approximate in a kind of A times B times C over 2 approximation the way we sometimes do for mass lesions. That is not possible for these tumors. You really need a careful volumetric analysis, and we're doing that in an increasingly automated fashion. And these images and this part of the quantitative assessment really is due to Denzel Faulkner, the PhD student from Rensselaer Polytech, who I mentioned is working with us in BioDesign. And so this particular tumor is one of the first ones I showed you earlier, 91% embolized. This is another one in our series. You can see it's largely embolized, but still incomplete. And by volume, we get almost 60% embolization extent. And here is one more just for comparison, a medial sphenoid wing meningioma that, as we've been learning, had significant supply also from the ophthalmic, and for that reason was only 31% embolized. So where is this taking us? Where I hope to be in 6 months or a year, once we have accrued a number more patients, we're already seeing distinct patterns in the ability to embolize tumors based on location, and the correspondence between tumor location and vascular patterns. And on some level, you might say this is obvious. It's obvious once you start looking at it. It's not necessarily obvious until you start looking at it. But there are clear patterns that emerge in the vascular supply to these tumors and the corresponding extent to which they can be completely embolized. So, for example, if you kind of categorize, meningiomas by the classic locations, and here I've just made a cartoon showing some of the classic locations. E, for example, is the kind of convexity meningioma that everybody knows and loves, and those convexity meningiomas tend to be almost exclusively supplied by the middle meningeal artery. If they're more posterior, oftentimes there is an occipital branch also that feeds them. And those tumors we're seeing, at least in a slightly more than anecdotal way now, can typically be very extensively embolized. Similarly, the lateral sphenoid wing meningiomas, C, are often almost completely supplied by middle meningeal artery, and as a result, or other internal maxillary artery branches, and can often be very extensively embolized. And we're increasingly now, due to analyses like this, able to quantify that. And I hope by the time we have 60 or 80 patients in the 3 MRI study group, we'll be able to do that in a really quite rigorous way and develop what I'm trying to call kind of an atlas of tumor embolization here. And we often ask, which patients is it even useful or justified to do an angiogram preoperatively to see if they can be embolized? And I think some of this work will begin to answer that question. And not surprisingly, the tumors, the D tumors, the tumors that are either medial sphenoid wing or clival or clinoidal, more towards the middle cranial fossa, midline, those tend to be much less amenable to embolization through external carotid branches. They tend to be fed by the meningohypophyseal trunk or by the infralateral trunk, and not easily embolized, at least by liquid or particle embolic agents. So we are developing an intuition around this now, and I hope that maybe in a year from now, we'll have enough patients accrued to really say these things in a rigorous way. And now, in the last couple of slides, I would like to show something maybe aspirational that we have tried to do and we have started thinking about, and that I really hope will be one of the outcomes of this work. And that is that not only will we learn more about tumor embolization, the biology and physiology of what's going on in these tumors, but we'll be able to change the surgical approach to these tumors from a maximally invasive cranial surgery to something, in some cases, more minimally invasive. So here is a lateral sphenoid wing meningioma. This was a 70-something-year-old woman, and she had already undergone multiple other medical procedures in her life, and this presented as a surprise to an already complex medical life that she had been living. And fortunately, this tumor was extensively and almost completely embolizable ultimately through her middle meningeal artery. And so you can see, now you're used to seeing these collections of images. The post-embolization preoperative MR showed almost complete loss of contrast uptake in this tumor. And so this is a patient of Dr. Betterson's, actually, and in the morning conference in which this was reviewed, I remember Dr. Betterson said, well, maybe it's possible to do a more minimalist approach to this tumor. We don't know, but what if the tumor is more liquefactive necrosis now than solid tumor? And would it be possible to attempt removal through, let's call it a large burr? And it was not as straightforward, I think, as we might have hoped, but I think the idea still stands, and I do hope that this will be something we continue to attempt. And ultimately, it did work out to not have to do a full-size traditional craniotomy, pterional type craniotomy for removal of this meningioma. And I think that you can see here the tumor was this fluffy white color, the same way as I showed you that marshmallow tumor at the beginning of the case. Although this was more fibrous and difficult to remove, not as easily aspiratable. And we do find that some of them, even when completely devascularized, don't become that, they don't develop that soft texture. We don't totally know why just yet. But I think the idea still is that if we can convert some of these, some large craniotomies into smaller craniotomies and a more minimally invasive procedures, there's something to be gained from tumor embolization beyond just limiting blood loss from the approach, really to fundamentally changing the way we think about how to approach even some of the very large, at least lateral sphenoid wing and convexity tumors. And I want to maybe go out on a limb here just a little bit. And I kind of alluded to this earlier, but as a group, we've seen just a tremendous uptick in the number of embolization procedures we've been doing over the last, say, 5 years because of the interest in chronic subdural hematomas and the possibility that middle meningeal artery embolization represents either an adjunct to the treatment of chronic subdural hematoma or even potentially a standalone treatment. And while I think there is a gathering of momentum around the idea that that's the case, still the randomized trials are still enrolling, so we won't really have level 1 evidence on that for some time. But still, we have more and more experience looking at the angiograms of chronic subdural hematomas, and they do look in many ways like convexity meningiomas. And there's some maybe understanding or intuition that we can give for why that might be the case. And we now know that basically you might think any lesion that sits in close apposition to the dura for a period of time recruits some of the same vessels that supply the dura. That may be sort of a hand-wavy intuition for why that is the case. And certainly that does seem to be on some level what is happening. And so I think that although this type of case that I showed with a convexity or lateral sphenoid wing meningioma may be more hard to come by, the idea of a embolization followed by a endoscope-assisted burr type procedure to treat a convexity lesion is going to be increasingly common. And so I'd like to show you just one case along these lines, maybe just as a little bit of inspiration. Certainly, it's something that has interested me over the last year. This is a patient with a acute on chronic subdural hematoma who did undergo middle meningeal artery embolization, and now in light of the tumor embolizations we've been showing, you can see, at least on an intuitive level, how sort of similar conceptually the embolization is for tumor and for subdural hematoma. And this is an endoscope-assisted evacuation of the hematoma. And this is just the endoscope working through a burr hole. And you can see here, this is the cortical surface. This is the subdural membrane that we're getting rid of. And you can see that even through a burr hole, these endoscope-assisted procedures give an excellent visualization, and there's even a fair amount of instrumentation that is helpful through the variety of endoscopes that we currently use. In these subdural hematoma cases, you can irrigate, you can use the bipolar cautery through the endoscope as I'm doing here, and you can also use a endoscopic grasping forceps and other instruments to try to remove both the membranes and pieces of the hematoma. And this is in many ways a much easier case than trying to remove a meningioma through a large burr hole. But I think that the intuition is still there, and I think that these cases may give us an opportunity to kind of practice some of the techniques that, if we develop them in a kind of conscientious way, may be increasingly useful in transforming some meningioma surgeries into more minimally invasive surgeries. So I hope to be able to come back, in a year or a year and a half and show you a full 100-patient case series on this work. And I think when we have those kinds of numbers, we'll be able to say some more definitive things, especially about the anatomic patterns and the patterns of tumor devascularization that we can achieve. But there is a fair amount of ongoing work with this whole collaboration, especially with the group at BioDesign. We are increasingly automating the image analysis, both the volumetric analysis of the tumors on MR and the angiographic images obtained in the angio suite. We will be compiling this as a very quantitative atlas of meningioma vascular anatomy with a classification both by MR degree of devascularization and classified by vascular pedicle. And we are working in work that I hope to present in the future on a very interesting novel embolic agents, and with a small startup company on a novel embolization microcatheter. So thank you very much for giving me the opportunity to present this morning, and I'd be very happy to answer questions and to hear your thoughts.
Thank you, Ben. Fantastic talk. If I can make a few comments in general. So, one of the things which I think is becoming more and more apparent, as you know, and, I had a recent journal club with the residents about this from a recent Nature paper from the Toronto group, is that really when we think of meningiomas as being these homogeneous tumors, they in fact have a complex heterogeneity, and they have a fairly reproducible and also equally complex genomic profile. And I think the more we begin to understand their biology and their specific, I would call it phenotypic behavior, I think the more this will give us insight into the patterns of embolization, vascularity, and treatment. And I think what we're seeing is not just variation in the genomic profile, but epigenetic changes too, based upon the location along the skull base and convexity. And I'm sure there's some other linkage there too, which would be, relatable to the not only vascular profile that you're seeing, but the degree of efficacy as well. So I think combining some of that work as a next level kind of analysis will be really fascinating to see. And then the second point I want to make is that I think, like you and I have discussed, I think there is going to be a lot of MRI-based, almost prognostication that we can begin to develop, which is, I believe, quantifiable. And I think there's patterns in the edema, for example. There may be patterns in the diffusion and the T2 signal. And I think beginning to think algorithmically about how these are predictable for not only embolization, extent to resection, and outcome is really going to be, I think, part of this whole, way we look at this category of tumors, and to start to think more broadly, more complex about this whole surgery, maybe different than historical ways where we just thought, meningioma, how do we take it out, and elaborate approaches. So really nice work, Ben. I'm really, very happy. Thank you for involving me in this project as well.
Yeah, thanks so much for the collaboration.
Yeah, Ben, it's a really good analysis. It shows that just like with subdural hematoma, intracerebral hemorrhage, and many of the things that we have long thought of as dormant type of pathologies, by applying new technology and new thought processes, we can make advances that we didn't even think of before. One of the things that we've discussed that I didn't see as part of your plan, but I would like to see as part, is the concept of micronavigation to the enhancing areas that remain after embolization, to add histological, intraoperative blood loss, maybe with a flow meter, but to add intraoperative analysis of heterogeneous areas after embolization. You said before, one of the problems is that you can only operate once, right? And so you can't operate on one that's not been embolized and one that's been embolized. But there are areas of tumor that have not been embolized, and we can micronavigate to those. So really, with one operation, you do get a chance to look at both unembolized parts and embolized parts. And you can have a static analysis of those two histopathologies or intraoperative findings or some sort of intraoperative measure. We've discussed whether it would be a flow meter or some, maybe even fluorescence. But you do have the opportunity to look at both parts of the tumor. That was one thing. And then I see that Jay is here. Jay, I wanted to ask you about the comment that was made earlier about the two different types of vascular supply, because one of the best outcomes I've ever had was a tumor you embolized where you did kill it through the meningohypophyseal trunks. This is the one that Ray knows about. And And so even though it wasn't a middle meningeal artery, it was one of those deeper ICA-based arteries. And I would like to be able to push that envelope a little bit as well. So I'm interested in your thoughts about that. You're on mute now, Jay.
Thanks. I always think people are so dopey when they do that, but in any case, yeah, I think so. First of all, I just want to start with saying, Ben, amazing work. Like, I remember us talking about, doing this sort of thing 2 years ago before you were even here, and the rigor you're bringing to it and the way you're putting it together and the thought, as you're presenting your stuff, I'm just thinking of just the way you're going to lay out your papers to help educate the entire community in the world about this, and essentially create a body of work and a foundation that's going to allow us to figure all of this out. And that ties exactly into Dr. Benderson's question, which is, which my answer is, it's the complexity of what we're trying to do. We talk about, Raj just said meningiomas are heterogeneous. Exactly. We're talking about embolizing meningiomas. We're talking about a disease where some are rock hard calcium, some are super fibrous, some are completely suckable. They're clearly completely different lesions, right? And then we're talking about embolization, like it's one thing, but there's massively different tools that we use to do those things. The challenge with the meningohypophyseal trunk and some of those other locations is when you use the liquid embolics or particulate embolics, things that can float free, then you run into risk of those things embolizing to unintended locations. And in fact, they can be extremely dangerous. However, oftentimes you can take down that blood supply with more conservative embolization methods, like with coils and things, which is the case that you recall. And so here's a case where we got a great result, but that result came from purely proximally shutting down the blood supply, rather than also deeply perfusing the tumor with embolate. And so we don't even really understand what the differences are in terms of what happens long-term to the tumor in those circumstances. And there are certainly going to be tumors that if you just occlude that acute blood supply, they may go away. Or the blood supply may go away and they may become there may be others where you need more diffuse injection. And with the data that Ben's collecting, I think we're going to get a lot more information on this and how it can be helpful, because I think that's a big part of what we're going to have to figure out. We have lots of different tools applied to a very, very heterogeneous disease, and figuring out exactly which combinations of which things is going to take. It's a pretty Herculean task, but I think it's pretty amazing. And the only other thought I wanted to say as a next step is, the other question becomes, like, when you embolize a subdural, you don't expect the subdural to disappear the next day or even necessarily the next week. We're doing chronic subdurals that are minimally or not symptomatic, with the expectation that the patient slowly resorbs it. So it does raise the question, for the patients that's very high risk for surgery, I certainly would not recommend this for a patient that could undergo an appropriate surgery. But for a very high risk patient for surgery, is there a role for, if you get an outstanding embolization, giving that lesion time to see if it does regress or liquefy or go in some other direction?
Yeah, we've discussed this, and I think there absolutely is. I mean, it's hard for me to imagine that some of these will revascularize because they're dead. What I see is dead tissue, and it would not surprise me if they would regress over time.
I would love to see an equivalent of the clip versus coil debate emerge for some meningiomas. I think that there's a potential to go down a route where we learn enough about which tumors might potentially be amenable to endovascular therapy alone. Probably not all of them. I don't think that's going to happen, but there may be a way, maybe a world in which we learn that some can be treated using endovascular techniques alone and not need surgery.
We should continue to push the minimally invasive approach to those tumors that have been really devascularized. Because some of these cases, just don't bleed, particularly the large ones that have been deeply embolized. There's just no blood loss. It's not that we're worried about quantitative blood loss. It's you worry about unable to see what you're doing.
Sure.
It's the bleeding, not the blood loss, actually. And so there's no bleeding that occurs. And it makes it a very different operation, particularly if you're inside a large tumor. You could have a very small access and get out a lot. And that one, I'm sure, would then regress. So if you were to core out that tumor from the inside and just let it be as an intended subtotal resection, that tumor then scanned weeks later, I think, would be much smaller.
There's a good question here in the chat from Dr. Singh about, which is probably worth adding to your research questions, is does embolization affect pathologic grading of these tumors? We start to see necrosis. Could that potentially interfere with the staging and grading of meningiomas histologically?
I think it'd be great to have a pathologist answer that question, but I don't think, unlike with gliomas, I don't think that having some necrosis in the specimen upstages the or upgrades from a WHO 1 to a WHO 2. I don't think that's part of the pathologic assessment. So I think the answer to that is no.
Well, that's the question that I had before, which is, what does the embolized dead part look like versus navigating to a part that still enhances? That's an IRB that we just need to write and file and do, because we could do that on tomorrow's cases. Right.
By the way, I do have in the appendix, but I didn't show it. I have done one or two of these, or well, collectively we have done one or two of these that that Dr. Hajimanias has taken for the full Hajimanias protocol with 5-ALA and synaptive and tractography and so on, and they're just beautiful sets of images for those cases. And some of the intra-op may go a few steps towards answering, Dr. Pedersen, one of the questions you asked, which is, what happens using a different adjunct like fluorescence? What happens to the, to the parts of the tumor that stop enhancing with contrast?
Great.
Then there's an additional question here about.
Wait, Peter, can I just say one thing real quick? I think that the question about the pathology highlights an important thing, that we really should be engaging with pathology on this and digging in on that exact analysis. That there's probably important pieces of information we could be getting there. Just something to think about.
Yeah, if I can make, sorry, one more comment about that too. A lot of the genomics work, as you guys know, we work with pathology, and really the immunohistochemistry diagnosis, just like glioma, just like Ben mentioned, is moving away from meningiomas as well. And the new grading categorization is really more on a genomic profile as well. So I don't think embolization and what we perceive as necrosis is going to upstage or change any of the pathology we do. And absolutely, and I know Ben and I have talked about this, working with pathology is going to be critical for this, because there actually are vascular markers in the pathology that give us yet another quantifiable metric to look at vascularity itself. So, really good point.
There's an additional question here about whether effective embolization, whether you've seen it have any impact on peritumoral edema.
In the few days after, well, let's put it this way: we've never seen it get worse in this series. I can't say that we have seen it get substantially better. I would love to be given the opportunity to wait longer in some of these patients and see. So I can't, at least in this series, give a definitive answer one way or the other.
I have seen it get worse. Sometimes big tumor with a lot of compression. In fact, we discuss Jay and I sometimes discuss the timing to have an ICU bed ready and to have the OR ready for the really big tumors with significant compression, just in case there's clinical deterioration. Not due to some giant change in the scan, but some sort of slightly increased pressure or edema. Okay, well, it's a very simple study, but we have to just ask the question, what's the difference between an embolized part of the tumor that no longer enhances pathologically and the one that has not been embolized and still enhances? That's a very important question that we haven't even addressed, which we can address. All right.
Absolutely.
Good stuff. Any other
Thank you,
comments or
everyone.
questions? No? Wonderful. Thanks, everyone.
Thank you.